Thank you everybody for coming tonight. It's interesting to know that we are living through history. Most of the time when it happens, you don't know it till years later, and then you look back at the things that were done or weren't done. But right now we know that we're living through it. And it makes it hard because there are so many decisions that are going to impact the future of the world that we're required to make with minimal knowledge. And we've been doing these COVID webinars since it started. We started this basically 15 months ago, and we came on air and told you all the things that we don't know about COVID. And then we started to learn more things and we told you those. And that's been our modus operandi, which is to share with you what we know, when we know it, to give you the information that you need to make decisions. So just a moment to talk about COVID. So worldwide, there have been 171 million COVID cases and 3.5 million deaths. In the United States, there are 33 million cases. So far, we have given 300 million vaccines in the United States to over 170 million people. We started out with EUAs, emergency use authorizations, and we now have these vaccines requesting full FDA approval. The vaccines were just approved for children over the age of 12. So lots of things happening, and they're happening very quickly. It's hard enough for me to understand everything that's going on. I can't imagine being a layperson and a parent and having to make all of these decisions. I know there's a lot of information out there. The important thing that you've done today is you've come to a trusted source. So when it comes to anything on the internet, I always tell my patients, my families, look and see where the information comes from. Is this a source that you would respect for anything else? Is this a source that just popped up in the last few months to give information about something, but really hasn't been there all along? Allied Physicians Group, we've been here for 13 years. We have over 30 offices across lower New York State. We take care of lots and lots of children. Many of you come to us. You know who we are. We're independently owned. We make choices based on what's good for our patients. None of us tonight are being paid for being here. None of us tonight make any money off of vaccines. One thing that did come up in the questions, I want everybody to know that COVID vaccine is free for everyone, no matter what your insurance, even if you don't have insurance, COVID vaccine is free. But there are lots of questions that you guys sent in, most of which are answered in our presentation. But I do have a whole list of questions, and we will go over some that either weren't answered or just really deserve some extra emphasis. I want everybody to take a moment, and we have a lot of meetings in Allied, and before the meetings, it's good to set an intention and think about why you're here tonight. Are you here to be open-minded and learn about what's going on? I know I'm here to hear what my colleagues have to say and to do the best that I can to answer all of your questions tonight. So with that, I'm going to allow my colleagues to introduce themselves, and I guess we'll go based on the row. So let's start with Dr. Robyn Kreiner.
All right. Hello, everybody. My name is Robyn Kreiner. I am an allergist and immunologist within the Allied Division. I work at Strauss Allergy. I'm pediatric trained, and I did my fellowship in the Bronx at Montefiore Medical Center in Allergy and Immunology. And just like many of you who have joined this webinar, I am a parent. I have 3 young kids, 2 almost 6 and almost 8. So I'm right there with you and trying to do the best research that I can to make sure that we make the most informed decision. And hopefully tonight we've all together with my colleagues and myself have tried to provide you the most up-to-date, accurate, and informative information so you can make the best decision possible for yourself, your children, your family, and those around you. Looking forward to talking tonight. Thank you.
Dr. Levene.
Hi, I'm Eric Levene. I'm a pediatrician in White Plains, New York. I've been a practicing pediatrician for 28 years. I am also a parent, and you're about to meet one of my children. And I look forward to talking about this. It's something that we do every day and encourage people to really think openly about vaccines.
Rachel.
I am Rachel Levene. I'm Dr. Levene's daughter. I'm a PhD candidate in molecular microbiology and a virologist by training. So I'm a scientist who studies viruses, and I have a special interest in respiratory viruses and emerging viruses like the coronavirus. And I was a participant in the Pfizer phase 3 trials. So I'm excited to share my experience throughout these trials as well tonight.
And don't worry, because we've worked with Rachel to make sure that she brings things down to a level that at least I can understand. So I think that'll be a little helpful. And Dr. Bosin.
Hi, thanks for letting me participate. I'm an obstetrician-gynecologist in New Jersey. I trained in New Jersey. I've actually known Dr. Eric Levene for about 30 years. I'm not one of his children, though. I am practicing. I spend about 70% of my time practicing OB and about 25% to 30% of my time in administrative duties. I'm the head of a very large labor and delivery unit in New Jersey and head of a large OB hospitalist program as well. So hopefully I'll bring be able to answer some of the same questions that I answer on a daily basis with about 5,000 of the patients who deliver in our center, and somewhere in the range of 7,500 to 8,000 triage patients that we see yearly.
Thank you. I do want to add, by the way, I'm a practicing pediatrician in Plainview. I've been practicing for over 30 years, and I am the mother of 3 children and a grandchild. So Bree, you want to start the presentation? Okay, Robyn, you're going to lead us off.
All right, so I'm just going to briefly touch on the COVID-19 vaccine and the importance of receiving it. This is just an overview, and then we're going to get into more detail as we go through the whole presentation. Next. All right. So over 1.32 billion doses of various COVID vaccines have been administered across the world without causing any type of allergic reaction or anaphylaxis. I know this is a big topic for many people and their fear of reactions to the vaccine. Anaphylaxis, especially as an allergist, is exceptionally rare. And in giving the COVID-19 vaccine, there really is no common culprit that we have found that is causing these reactions. We do know it has nothing to do with food allergens, as they are not present in any of the COVID vaccines. And as you have seen, rare things will occur when a large number of people are involved, especially when the media is spotlighting this new vaccine that has come into play. And as physicians and providers and scientists, understanding the risk versus the benefit is very helpful in medical decision-making for both the patient and the provider. And just to, an overview is the risk for any allergic reaction to a COVID vaccine is extremely low. I know we've heard within the first release of the COVID vaccine, there were a few cases of anaphylaxis. And not everything is anaphylaxis, even though it might be depicted as that. There's vasovagal responses, there's anaphylactoid responses or reactions that might mimic anaphylaxis. And just so everybody who's listening knows, there's no food, there's no latex, there's no environmental allergens, there's no venom allergens present in this vaccine. Next. So just to give you a general sense, severe allergic reactions in general to vaccine are very rare. As you can see here from this chart, the diphtheria, tetanus, and pertussis vaccine, the risk of a severe allergic reaction is about 1 per 1 million doses. For the measles, mumps, and rubella vaccine, which many of you are required to get and have gotten, the risk is less than 1 per 1 million doses. And with the COVID vaccine, we've seen about 33 cases of anaphylaxis, or what we think is anaphylaxis, in the over 25 million vaccinations that have been given, which is about 1.31 cases per million vaccine doses. And 100% of them have recovered with no deaths. So, the MMR has almost completely eradicated the measles, mumps, and rubella if you do get it. And that just goes to show how important herd immunity is, or vaccinating everybody around you. Next. So the COVID vaccine components and excipients. As you know, many vaccine components contain ingredients such as egg proteins, formaldehyde, gelatin, neomycin, and thimerosal. And these can all cause immediate reactions in many individuals. And as we saw before, the cases are very, very low. With the COVID vaccine, none of those products are in the COVID vaccine. But there are two excipients that we've heard a lot about. And those are PEG, or polyethylene glycol, and polysorbate, which are excipients that help to make the vaccine better absorbed and help to promote the immune response in individuals. Next. So what do we know about the Pfizer, BioNTech, and the Moderna vaccines? So as you can see here, I put a side-by-side chart, and they are both mRNA vaccines, which have been studied for years. Okay, you have the active ingredients, which is the mRNA. You have inactive ingredients. The ones I'm spotlighting here is that polyethylene glycol we've heard a lot about. And then we have inactive ingredients like salts, sugars, and buffers. And for the salts, sugars, and buffers, it's extremely, extremely hard to react to these ingredients. Next. So what is polyethylene glycol? So polyethylene glycol is a common water-soluble ingredient that's used in many products. It's used as a laxative. It's an excipient in many pharmaceutical products. And it's also an excipient that's fused to protein medication to help slow the clearance from the blood so it stays around longer. And some of you may have heard of Miralax, which is a common ingredient to help with constipation, which some of you may have had an adverse reaction to. And I'll go into that later on. Next. So how do those mRNA vaccines compare to the Janssen or the J&J vaccine? So you have the Pfizer or BioNTech mRNA vaccine, the Moderna vaccine, and the Janssen vaccine. The first two you see listed here are mRNA, and the third one listed is a viral vector or an adenovirus vector. And the idea behind the adenovirus vector is it's basically a vessel in order to help get into your body so that the immune system can elicit an immune response to the spike protein, which is similar to the spike protein that's on the outside of the COVID vaccine, COVID-19 vaccine. What's different about the inactive ingredients in the J&J vaccine is that polysorbate 80, which you see listed in the third column, second down. Now, sometimes people are thinking that that might be one of the causes of some reactions that might be caused by the J&J. But again, more studies need to be done to truly confirm if that's the culprit for some of these reactions. And again, you have similar inactive ingredients like sodium chloride, which is basically salt, sodium hydroxide, and water. So again, no food products, no venoms, latex, no environmental allergens. Next. So why are polysorbates important? Well, these are also very similar to polyethylene glycol in that they help with the absorption. So it helps to bind and helps to promote an immune response. And as you can see here, this little chart or the organic structures and molecules, they sometimes can be similar to the polyethylene glycol. So sometimes you might see that there may be some cross-reactivity in studies have shown. And you find polysorbates in many vaccines that you've already received. The Tdap or tetanus, diphtheria, and pertussis vaccine, the influenza vaccine, the human papillomavirus vaccine, and the list goes on, but hepatitis, rotavirus, polio, zoster, the meningitis vaccine. So they're very common, and you've received many of these before. Next. So just a quick summary about the J&J allergic reactions. And again, I come from an allergy background, so a lot of this is allergy focused. But there was only one hypersensitivity reaction at the time that I provided these slides. Only one hypersensitivity reaction likely related to the vaccine, and it was not classified as anaphylaxis. It was delayed urticaria or hives 2 days after, and some swelling and a little bit of respiratory distress 4 days after, which is unusual and uncommon, but it was reported. And there was also one case of anaphylaxis among 110,000 in an ongoing open label study in South Africa. Next. So many people have asked prior to the lecture being given, what happens if I get a large reaction to the first vaccine? So injection site reactions are not a contraindication to the next vaccine, the second vaccine, or even boosters if those are necessary in the future. So what we're recommending is to ice the location, maybe take an antihistamine like fexofenadine, cetirizine, anything over the counter, and maybe some topical corticosteroids to help decrease any swelling. We are not recommending any antibiotics for those large local reactions. Next. So just some important information that I've come across and might be helpful for anybody who's questioning, but delayed reactions are not a contraindication to getting that second dose of the mRNA vaccine, such as Moderna and Pfizer. If you've had a severe immediate reaction within 4 hours, any allergist will be happy to see you to evaluate further. Many people have asked about skin testing to polyethylene glycol, or people who have had reactions to Miralax, or Go Lightly, which is a prep for colonoscopies. And sometimes they've been helpful to do these skin testing, but if the testing is negative, it reassures you. But if it's positive, you may actually be fine getting the vaccine had the testing not be done. So it's very important to take that clinical history into account and weigh the benefits and the risks. So prior tolerance of a vaccine containing polysorbate 80, which I showed you before, many of those vaccines suggest that you may tolerate that J&J vaccine. And as we all know, anaphylaxis is treatable with epinephrine, but complications from COVID-19 may not be as easy to treat. So some takeaway messages from my portion. Vaccines are nearly 100% effective for this vaccine at preventing hospitalization and death from COVID-19. Scientists, like Rachel, have been working on technology used in the COVID-19 vaccine for 20 years. So this is not new. I know this is the first mRNA vaccine in the US, but it's not a new vaccine. It's not a new topic. More than 100,000 people from diverse backgrounds have taken part in these vaccine trials. The vast majority of doctors who have been offered the vaccine have taken it, and there is no cost to the vaccine, as Dr. Fierstein has mentioned before, with or without insurance. Next. So children in the COVID-19 vaccine. So why should my child get it if they're asymptomatic or they really don't have complications? Well, we don't know which kids might get it and might get those severe complications. Also, many of these vaccine preventable diseases are transmitted from person to person. So vaccination not only protects the child or the recipient, but it also directly protects others who cannot be vaccinated or who do not mount proper immune response to several of these vaccines. And by having everybody immunized, it provides something called herd immunity, which prevents yourself and those around you from preventing that disease. Next. So a few more questions that I just wanted to touch on. Why was this the first mRNA vaccine approved? So as I said before, it's been studied for years, but has not been licensed for use. Vaccines are very, very costly and they take time. You have to get all these study participants, you have to get enrollment, you have to get cooperation, you have to make sure they stay in the trial. And there are many mRNA vaccines being studied, but the urgency was so dire during this pandemic that a lot of the focus was trying to get this approved quickly, efficiently, and safely. So many people say, was it rushed? No, no corners were cut. Studies are out there for anybody who wants to that can read them. I don't know if anybody wants to read them. They may put you to sleep at night, but they are out there for anybody who wants. It enrolled over 30 to 40,000 study participants. And in a way, it was rushed, like I said before, because we needed this to become available once all those studies were safely completed and reviewed. So what about the J&J? So it is not an mRNA vaccine. It's an adenovirus vector or an inactivated virus. So it does not cause the virus. You take out the active part and you attach the inactive part to that spike protein on the COVID vaccine. And that serves as a vehicle to enter your body with that vaccination. And your body then goes ahead and mounts an immune response to that spike protein. So if you're ever exposed to it, you have B and T cells that come along and recognize and attack that virus to prevent serious complications and even death. Next. So again, why should my kid get this vaccine? So the virus can only spread from host to host. It doesn't do anything by itself. It needs us to spread the virus. So if enough people get it and there's no longer enough hosts to spread the virus, this in turn helps stop the spread. And that's the idea behind herd immunity. So what does the efficacy rate mean? So we were looking for about 50% efficacy, and we blew way past that. So you've heard over 90%, 89%, 97%. This is very good for a vaccine, for those who have been around and studied vaccines for a long time. And again, what about those immediate reactions that we're hearing about? Well, these rates are actually approaching that of other vaccines. So the more vaccinations that are given, the more they have come down to the other common vaccinations that we're given. So, if you were to ask me if I would vaccinate my children, I would. I believe in the benefits outweighing the risks. And I'll leave it for my other counterparts to continue.
All right, so I'll jump right into the science behind the COVID-19 vaccines. Just as a refresher, I'm Rachel. I am a scientist who studies viruses and was also a participant in these trials. Next slide. So we vaccinate to prevent infection. And the reason why we can do this is because our immune system has this property called memory. It has the ability to remember the past infections that we've had before, so we don't get sick with the same infection again. So vaccines elicit that protective response by mimicking the first infection. But because you're not actually getting the first infection, you have none of the risks that are associated with natural infection. So how are we able to make vaccines that mimic infection? Next slide. So the oldest, most of the vaccines that we have as part of the childhood series take two main forms. And the oldest, or the one that's kind of, they're all tried and true, but the oldest one out there is a dead or weakened version of whatever causes the infection. So I think for the purposes of tonight, let's say viruses, because that's what's on our mind here. So the way this works is we grow up a ton of virus in these large stainless steel cylinders called bioreactors, and grow up a ton of it, and then we kill it, usually with very, very high temperatures and pressure. And then that gets injected into us, and our immune system doesn't know any better that it's dead and it can't replicate. So it mounts a response and it goes to war against what it perceives as an invader. And it makes antibodies, which are the foot soldiers of our immune system. You can see them here in red and purple and green and blue. So we have a lot of these on the market, our annual influenza vaccine, the hepatitis A vaccine, and the original Salk polio vaccine. And although this method works, it does have some drawbacks. So as I mentioned before, it requires a ton of virus to be made. So I like to use the flu vaccine as an example, because for this upcoming flu season, when we will all get vaccinated against flu in later in the fall, we actually started making the vaccine this past February. So it requires almost a year of production. And with COVID, we didn't have that time because every day counted. And manufacturing involves a lot of living biological materials. So we can't grow virus without cells in those large bioreactors that I talked about earlier. And that increases time because we need to build these facilities in order to house these bioreactors. And with COVID, again, we didn't have that time. And the other thing is that the immune response from these vaccines can be a little bit what's called messy. the antibodies are not always the right antibodies for protection. So we've heard a lot about neutralizing antibodies in the media. And what this really means is that it's an antibody that recognizes the protein on the surface of the virus in purple here. And that's spike for the virus that causes COVID-19. So we want antibodies that only recognize the protein on the surface, or spike. But because we're injecting the entire virus, although it's dead, the immune system can make antibodies to other parts of the virus. And these aren't as protective, and we don't really want them. So one way to get around that is to make a vaccine that is just the protein on the surface of the virus. And this is called a protein subunit vaccine. And we have this for hepatitis B, pertussis or whooping cough, meningitis, and pneumococcus. And we know that the antibodies are always the right antibodies for protection. They're always those neutralizing antibodies. But this method also has some drawbacks related to the time it takes to manufacture and produce it. And with COVID, every day counted. So like dead or weakened versions of the virus, it requires living biological materials, usually cells, which for manufacturing, which increases the time and the chances for things to go wrong. And with proteins, one thing we worry about is that it needs to be the right shape or structure 100% of the time, because our immune system recognizes shapes and structures. So we would need to make sure that any manufacturing is right 100% of the time. And it really just takes a lot of time to ensure that the manufacturing production lines can do this. And while we had this time with other infectious diseases, we didn't have this time with COVID. So how do we get around that? Next slide. Well, our body does this every single day to make all of the proteins in our body, like our hair, nails, and skin. So what if we could just have our own cells make the protein that we want to use as the vaccine? And this is called the central dogma of biology. And it's something we've known about for decades and decades and decades. And if there's any teenagers listening along tonight, you've definitely learned about this in your biology class. So what this says is that the DNA, which is in the nucleus or the control center of our cells, makes a message called messenger RNA or mRNA. One thing I want to point out is that mRNA cannot ever make DNA in humans. So you can't go backwards, you can only go forwards. So mRNA cannot modify or change our DNA. And then mRNA makes proteins. So what if we can just have the message to make spike? Next slide. And these are exactly what the 3 vaccines that we have do. So 2 of them, Pfizer and Moderna, do it in the form of mRNA. And the key thing that allowed this vaccine to be made what is relatively quickly is modern DNA sequencing technology. Is that on January 10th, 2020, we knew the sequence of the entire virus. We knew its genetic code. So we also knew the sequence of the spike protein on the surface of the virus. So we can then make the mRNA for that. And then to get the mRNA into our cells, we need to wrap it up in a layer of like oily fats. And these are called lipid nanoparticles. So that is injected into us. And our cells know exactly what to do once they see that mRNA, because it's no different than the mRNA that encodes for other proteins like our hair, our nails, or our skin. So the cells make little spike proteins, and then our immune system says, hey, that's not a normal protein like our hair, nails, and skin. And our immune system thinks that we're being invaded by COVID, but we're not, because it's just a protein, and it makes antibodies. So those antibodies are left behind while the mRNA and spike are chewed up and destroyed as cellular garbage. The antibodies are left so that the next time we see spike on the real virus, we're ready to attack it before the virus can do any damage. And the J&J vaccine is very, very similar, but instead of making spike in the form of mRNA, it makes it in DNA. And it's wrapped up in a viral vector or just a vessel to get it into the cell. I tend to think about it as, kind of like a fork that we use to get food from our plate into our mouth. So some specs on them, 2 doses versus 1 dose, and we know that they're extraordinarily effective vaccines. So how do we know this? Next slide. So I'm going to talk mostly about Pfizer's trial because it's the furthest along in the pediatric trials, but all of the results that we've seen with Moderna are very, very similar. So to make sure that these vaccines actually work in the real world population, Pfizer enrolled about 44,000 individuals, including myself, and half of them received the vaccine and half of them received a saltwater injection or a placebo. And no one knew what you got. So I didn't know what I was getting when I got it. And if the vaccine were effective or it worked, we would expect to see that those that got the vaccine did not get COVID, while those that got the saltwater injection or the placebo got COVID. And indeed, that is exactly what we saw. So if we look at cases of COVID as a function of, days after participants got their first dose, we see that there were a large number of cases accumulated in the placebo group, while there were relatively few in the vaccine group. And that led to an efficacy of 95%. So what that means is that the vaccine reduced the risk of symptomatic COVID by 95%. And that is an extraordinarily effective vaccine. Next slide. They also did one other thing as well. They measured our antibody levels in the trial. So those foot soldiers of our immune system. And they saw robust antibody levels, so very high antibody levels that were higher than people that had recovered from COVID-19 or higher than what was in convalescent plasma. So we know that these antibodies are likely what's called a correlate of protection. We know that they are a marker for what is protective. Next slide. So now that we know that the vaccine is effective in people 16 and older, we need to be able to vaccinate adolescents and children in order to get to herd immunity. So the next step is they did a trial in adolescents. So they enrolled about 2,200 adolescents. And again, they received either the vaccine or the placebo. And then like the adults, they were monitored for symptomatic COVID and their antibody levels were measured. And there were 18 cases of COVID-19 in the placebo group, while there were none in the vaccine group, and the antibody levels in the vaccine group were very, very similar, if not higher than young adults, which shows that this vaccine is effective. And next slide, we have an efficacy rate of 100% against symptomatic COVID. And this is because there were 0 cases in the vaccine group. So it reduced the risk of COVID by 100% in this age group. Next slide. And last week, we also got the same results from the Moderna vaccine. And in science and medicine, we love to see things repeat. It's kind of like the gold standard. So this was really great news. And both of these companies have applied for a full authorization, no different than any other vaccine on the market. And we expect to hear back from that in a couple months. Next slide. So all of these trials were set up to determine if the vaccine prevented against symptomatic illness from COVID-19. And the one thing that we didn't know from these trials is whether or not the vaccines would prevent against asymptomatic infection and transmission. The trials weren't designed or set up in a way to measure this. So what we, in order to figure this out, we actually looked at the real world. We looked at people that were vaccinated and used people that were undergoing routine surveillance testing as part of workplace COVID safety precautions, like in hospitals. And what they saw is that vaccinated individuals did not have any of the virus that causes COVID-19 or SARS-CoV-2 in their nose and mouth, while unvaccinated people did. So this meant that vaccinated people, when we talk, speak, or breathe, we're not expelling virus on our respiratory droplets. So we're not at risk. We're not putting anyone else at risk because there's no virus in us. We're not carrying it. while an unvaccinated person can still carry it and can still get sick. And this is what led the CDC to say vaccinated individuals no longer need to wear masks. Next slide. So the next step is really being able to vaccinate children under 12. So the concern is not really so much efficacy. Everything that we know tells us that it's very likely the vaccine will work in children, but we have to make sure. So these are what's called bridging trials. So we're really going to look at how similar children's antibody levels are to that of young adults, because we know these antibodies are protective. So the other thing is that children tend to have very robust immune systems, and they may not need as high of a dose as adults to mount that effective response. And the adult dose may not be tolerable. So that is a huge reason why we need to do these trials. So the way they're done is we start with what's called age de-escalation. So we start with the oldest children first, and then we work down to 2 years to 6 months once we have sufficient safety data saying that the dose is safe and the vaccine is safe in older children. And at the same time that we age de-escalate, we dose escalate. So this is very similar to what was done in the adult phase 1 trials. You start with the lowest possible doses and then work up to the full adult dose once we know that children are able to tolerate those lower doses first. Next slide. So the big question with these trials is really, what dose do we give to kids to get that robust and protective immune response? So where are we on our ability to do this? Next slide. So both Pfizer and Moderna have started these age de-escalation trials. And Moderna tends to have some fun names for the trials, like Kid Cove. But the first part of the trials is the same. It's the age de-escalation and the dose escalation. And then these children will have their antibody levels measured. It's just a blood draw. And then we'll look and see how similar these children's antibodies levels are to that of young adults like myself in the trials. And then once we get a dose that's safe and that children are tolerating well and children that are tolerating well, we move to these the larger part of the trial, which is part 2, where they're randomly assigned the vaccine or the placebo, and we're looking at it in a larger number of children to make a more informed decision. And Pfizer expects results for children older than 2 in September of 2021, and then for children younger than that, probably sometime in Q4. So next slide. I just want to take a minute or two to talk about the variants, because I've been getting a lot of questions about these. Next slide. So one fact that permeates virology is that viruses change or they mutate, and they do this to get better at infecting people. And they do this by changing their genetic code, and we can make very pretty maps, as the New York Times did, of these variants. Next slide. We've all heard, the South African variant, the UK variant. We can call them with numbers. The WHO actually said today we're going to call them by Greek letters. And some of them may make the virus more infectious or more transmissible, be able to infect people more easily. Some of them may make the virus more pathogenic or more severe. And some of them may slightly reduce the effectiveness of the vaccines. Next slide. So how are they doing that? And that's what I want to talk about. Next slide. So the way they could reduce the effectiveness of the vaccine comes down to shape. As I said before, our immune system, it's all about shape. So our antibodies bind to spike on the surface of the virus to neutralize it like a key into a lock, the same way you would put your house key into its lock. So when mutations change the shape of spike on the surface of the virus, the antibodies that we have from the vaccine may no longer be able to bind it as well because they don't fit. It's like putting the wrong key into a lock. And this is what's called the virus escaping vaccine or natural protection. Next slide. I like to say it's also like putting a square peg in a round hole. But like putting a square peg into a round hole, what we can, the square peg does make some contacts with the outside of the round hole. So the antibodies are likely able to bind spike, at least to some degree. Next slide. And we know that the antibodies that are able to bind spike to some degree are protective, because current evidence, not only from laboratory studies and clinical trials, which were done at the time that the variants were emerging, and in real world evidence, suggests that our vaccines are protective against these new variants, from all the way from mild illness up to severe illness and hospitalization. But should we need to change the vaccine to meet any new variant is not something new. We do this every year when it comes to flu vaccines. So it's definitely something we can do. And the mRNA technology that we use for the vaccine is actually much more amenable to making quick changes. So we will be able to turn the vaccine around much more quickly than we would with flu. Next slide. So the bottom line is, the higher the rates of vaccination here and across the world, the less variants will emerge, and the threat of variants that can escape the vaccine will diminish, because there'll be less virus replicating. So if the virus isn't replicating, it can't change, and we can stop it from replicating by vaccination. Next slide. So even if the vaccine, protects against all the variants of concern, the question then becomes, do we need to be vaccinated every year with, third and fourth boosters? And it's really, in short, it's really too early to tell, and only time will give us this answer. So the way that we can figure this out is we can monitor trial participants like myself to see how our antibody levels change, and if we, start to get COVID after a period of time. And one thing we do know is that 6 months after the second dose, our antibody levels are stable and they haven't changed, which is great news. And most clinical trial patients have been vaccinated now for about 8-9 months. So the next data point that they'll collect is a year after vaccination. So in about 3 months, we'll start to get more answers about whether or not our antibody levels have changed at all. So some vaccine series have multiple boosters, some don't. We don't know yet for COVID, and only time is going to give us this answer. We can't rush that. And to make sure that it would be safe to give a booster, Pfizer and Moderna are testing boosters as well, of the original one and of ones that specifically target the variants. Next slide. So some takeaway messages. These vaccines elicit better and stronger protection than natural infection, and they have none of the risks that are associated with natural infection. They're safe and extraordinarily effective at preventing both illness and infection and transmission. They protect against all the variants of concern, and it's really too early to know if or when we may need a booster. And with that, I will pass over the torch.
Thank you very much. Rachel, that was great. Next slide, please. So pregnancy and COVID-19, most infected pregnant persons recover without undergoing hospitalizations, meaning they have mild disease or a carrier state. But rapid clinical deterioration can occur, and symptomatic pregnant patients appear to be at increased risk of severe disease and death compared with symptomatic non-pregnant females of similar reproductive age. The risk factors for severe disease and death in pregnancy include an older mean age of greater than 35, obesity, and pre-existing medical comorbidities, especially hypertension and diabetes. Next slide, please. Before people get pregnant, or meaning the preconception stage, because we do get a lot of questions about this, is, the pandemic itself has prompted questions about whether patients should consider postponing pregnancy because of potential viral related risks to the mother, fetus, and newborn, and this has not been proven. Pregnancy related risks associated with COVID-19 have not been established, and limited evidence suggests that pregnancy-related risks are not high. So these are all good. Vaccines for prevention of COVID-19 are not thought to affect fertility. This comes up, questions asked all the time, but the definition of infertility is actually 1 year of attempting to get pregnant without success. These vaccines haven't been around enough to fulfill that criteria. Pregnancy testing is not a requirement prior to receiving any COVID-19 vaccine, and it's not necessary to delay pregnancy after vaccine, which means it doesn't matter whether you're pregnant or not when you get your first vaccine or second. Next slide, please. Pregnancy and COVID-19, again, data support maternal COVID-19 infection is not associated with a high risk for neonatal problems. Over 95% of newborns with COVID-positive mothers have been in good condition at birth. Pregnancy does not increase the susceptibility to COVID. And there's no standard occupational guidance for pregnant healthcare workers regarding work restrictions in a COVID environment. Next slide, please. I can't see part of my slide, but COVID transmission from the mom to to a fetus or a newborn in utero or via a uteroplacental transfer remains very, very small. Limited information on increase, but very rare stillbirth occurs, but it's actually thought that it may be due to a very, very sick mom where the fetus may die in utero, or disruptions in prenatal care because people were not getting to doctors because of COVID. So that data is not mature and cannot be really expanded upon. Next slide, please. Vaccines, as Rachel said, produce antibodies which protect pregnant patients and transfer those antibodies to give immunity against COVID in newborns after maternal vaccination. In a prospective study of 84 pregnant and 31 lactating and 16 non-pregnant women who received the mRNA COVID vaccine virus in March, 3 groups had equivalent vaccine-induced immune response, meaning that whether it was an mRNA virus or an adenovirus, had the same response. I think Rachel spoke about this, but again, antibody titers were higher than those induced by having a COVID infection during pregnancy, and vaccine-generated antibodies were present on umbilical cord and breast milk samples. Pregnant and non-pregnant vaccinated individuals developed cross-reactive immune responses against the COVID variants, which was important. Next slide, please. I just want to talk about 3 areas: the CDC, ACOG, which is the American College of Obstetricians and Gynecologists, and finally, the Society for Maternal Fetal Medicine. The Centers for Disease Control and Prevention state that pregnant persons are eligible for and should receive to receive a COVID vaccine. Over 94,000 participants in the CDC's Be Safe program and Health Checker had indicated that they were pregnant at the time of vaccination. And the registry had no safety signals against the vaccine with respect to miscarriage, congenital anomalies, fetal growth, preterm birth, stillbirth, or neonatal death. Again, very, very, these are really, really good findings. Next, please. The American College of Obstetricians and Gynecologists vaccine recommendations. I check this site on a daily basis, as I did this morning, and nothing has really changed since I wrote the slides. ACOG does not directly come out and state that pregnant patients should get the vaccine, but they do state that pregnant individuals should have access to COVID-19 vaccines. Vaccines should be offered to both lactating and non-lactating individuals. Those considering the vaccine should have safety and efficacy data available. Patients should have a conversation with their OB provider regarding the vaccine if requested. Possible side effects should be part of any counseling, and especially if asked for. And the conversation with a provider should not be required prior to obtaining a vaccination. The claims that COVID vaccination causing infertility, as I stated before, are unproven, and those declining vaccination should be supported in their decision. And these are all from ACOG. It's interesting here because the patient should have a conversation with their obstetrical provider regarding the vaccine, which is in the middle of the slide. But to my knowledge, where I am in New Jersey, there are no providers that are actually giving the vaccine. So patients will have a conversation or counseling either in person or via telemed, but go elsewhere for that vaccine. Next slide, please. The Society for Maternal Fetal Medicine also has recommendations, as the CDC and ACOG. And the Society for Maternal Fetal Medicine is that society for the doctors that practice high-risk obstetrics. They have a little bit different language. The SMFM strongly recommends that pregnant and lactating people have access to the COVID vaccine and that they engage in a discussion about potential benefits and unknown risks with their healthcare providers regarding the receipt of the vaccine. Again, I think it's very difficult to discuss unknown risks with something especially this early. The vaccine should be offered independent of trimester, which of course goes to the fact what the CDC said, that you don't need a pregnancy test in order to get the vaccine. So it could be very, very early in your first trimester versus late in your third trimester. The vaccine should be offered regardless of a history of symptomatic or asymptomatic infection. Next slide, please. Some patients may reasonably elect to defer vaccination after weighing their personal risk of COVID-19 exposure and disease severity against the limited but increasingly reassuring data regarding the safety and efficacy of COVID-19 vaccines during pregnancy. Patients who are at higher risk of exposure to COVID or at the highest risk of having severe disease, meaning if you're diabetic or obese or have heart disease or over the age of 35, may benefit most from vaccination. One of the things that's emerging too, which we all get questions about, is which vaccine should I have? The J&J vaccine, which is the adenovirus vector, has been associated with a very, very slight increased risk of having a blood clot problem like a DVT. It's therefore reasonable for patients to choose in pregnancy either the Pfizer or Moderna if it's available. But if they're not available, it's certainly reasonable to take the J&J vaccine. Next slide. Myths.
That's me.
Yeah.
All right. So there are lots of myths going around about the vaccine, and in researching it, I found a lot of them that I didn't even know were going around. But the first myth I'm going to discuss is that the vaccine was rushed. Rachel and Dr. Kreiner have discussed this, but just to review, the technology is not new. It's over 2 decades old. It's been used to develop other vaccines for Zika, flu, RSV, SARS-1, and it's currently being looked at to have cancer treatments and autoimmune and treat autoimmune diseases. And once the genetic code was shared, it took days, not years, to find that vaccine. The developers did not skip any steps. Red tape was definitely eliminated, and some steps were done in an overlapping manner. Also, social media finally became our friend here, and it was a help in recruiting people like Rachel to engage them and get them interested to volunteer for the vaccine trials. The other thing that really helped us, unfortunately, was there was so much illness. It was so widespread, it didn't take long to find out that the vaccines were working. And lastly, the vaccine makers started making this vaccine prior to having any other approvals that were in place. This was never, ever done before. So the vaccine was not rushed. The second myth was that the vaccine will cause me to have COVID. And as Rachel discussed before, the vaccine does not contain any live virus or dead virus. It cannot cause you to have the illness. One of the other myths was, what about unknown or long-term side effects? Most side effects from vaccines are seen within 6 weeks. After that, we don't usually see any side effects from vaccines. Well, it's been 10 months, and as Dr. Fierstein said, over 300 million doses were administered, and we haven't seen any, which is great. The fourth myth is that it contains some controversial substances. As you heard from Rachel and Dr. Kreiner, the vaccine has 10 substances: the messenger RNA, lipids or fats, salts, and sugars. We find these in other vaccines, IV medications, IV fluids, and that the mRNA vaccines were not developed using any fetal tissues. So that is a complete fallacy, okay? The next myth was that after the vaccine that I'll test positive on a nasal swab. No, you will not test positive on a nasal swab at all. You will test positive for a blood test on antibodies, but you will not test positive on any nasal swab, PCR, or rapid. And of course, the big one, infertility. Dr. Bosin said a bunch of things about this, but this myth comes from that the spike protein on the COVID virus and a placental protein were similar. Well, they're not. They share a few amino acids, but they're different and distinct, and our immune systems do recognize them as completely different. Actually, during the Pfizer trials, 23 women in the study became pregnant. Only one woman had a miscarriage, and that woman happened to have been in the placebo group. Then along those lines, there's lots of chatter online now about that the vaccine will affect a woman's menstrual cycle. Interestingly, some of the myths are that just being near somebody who is vaccinated would affect a woman's menstrual cycle, which certainly will not happen. There's lots of anecdotal reports of women having changes in their menstrual cycle, such as it being heavier or lighter or longer or different. We know that many things will affect a woman's menstrual cycles, stress, and Dr. Bosin can certainly speak up if there's anything I'm leaving out. We currently not sure if there's any link, but Dr. Caitlin Jetlina, who's also known as your local epidemiologist, she feels that this may be a sign that the vaccine is working. Your body is making an immune response to the vaccine, and that the transient effects like fever and body aches, and the stress and anxiety of getting the vaccine are causing short-lived changes. Just so you know, there was a study done of 177 women who actually had COVID. 25% had changes in their menstrual volume, 20% had lighter periods, and 19% had longer periods. There is now an ongoing study looking at this, and we can certainly send you any links if that's something you want to participate in. Just a small study, so we know, because people say it affects the fertility in men. No, but we do know that men getting COVID, there is an increase in erectile dysfunction, so that may be causing some infertility. The next myth was it cannot affect, that it affects puberty and development. There, as Rachel discussed, there's no way for messenger RNA to get into our DNA. It doesn't work in a reverse way. So this also is a fallacy. One of the other big ones is if you've had COVID, you don't need the vaccine. So as you've heard us say that, no, this is not true. Some studies are showing that there's better protection from the vaccine than from the illness. And probably there's better protection against the variants and potentially longer protection when you get the vaccine. We did have some new information in the last week or so that said that if you've had the illness and then got your 2 vaccines, you probably won't need a booster if one is recommended. But this, of course, is still under investigation. The next one is breastfeeding. There's a rumor saying that if you've gotten the vaccine, that if you breastfeed, you will harm your child. In fact, actually, this is wrong, and it's in reverse. Actually, it's showing that women are passing along protective antibodies through the breast milk to their infant. Okay. The last myth, and this, of course, is my favorite myth, is that the vaccine is actually a microchip to track people. Well, this is false. I like to say, if the government wants to know where we're buying our groceries, they only have to talk to Visa and Amazon. that as parents, we know, and everybody else knows, that basically our cell phones are tracking us. And as parents, we know we're tracking our kids, but please no one tell Rachel that that's how I track her. Okay, next slide. So the Pfizer vaccine and the side effects in teenagers. Basically, what we're talking about is what's been in the news in the last week or so, and that is myocarditis. Since April of this year, there have been a few reports of myocarditis. First, what is myocarditis? Myocarditis is an inflammation of the heart muscle. It's usually caused by viruses, such as adenovirus and other viruses that usually occur in the springtime. Many cardiologists think of this time of year as myocarditis season. What are the symptoms? Symptoms of myocarditis are chest pain, fatigue, fever, muscle aches, rapid breathing, rapid heart rate. Dr. Paul Alfit of the Vaccine Education Center at Children's Hospital of Philadelphia states there are 100 to 200 cases of myocarditis per million people per year on a regular basis, excluding anything about vaccines. That leads to over 3 million cases of myocarditis per year. And the thought is that this is underreported because there's many what we call asymptomatic or subclinical cases. So there's a lot of it around. But the reports have been rare, mostly in males greater than 16. We haven't seen any reports in the 12 to 15 age group, and usually under 30 years of age, and usually up to about 4 days after the second dose. All the cases are self-limited and resolve on their own with no long-term problems that we know of currently. Currently, the number of cases that we've seen is no higher than what we would have normally seen at this time of year. Also, in reviewing the literature, in Israel, they reported 62 cases of myocarditis out of 5 million doses. Given that, that's a risk of 0.001%. Paul Offit states that if this was a real risk, it would be about 1 in 5 million. Just for a comparison, you have a 1 in 700,000 risk of getting struck by lightning. Also, at the end of May, there was an article in the Journal of the American Medical Association that looked at competitive athletes who got COVID illness, not the vaccine, but the illness. So that was about 1,600 athletes, and about 0.31% had myocarditis by symptoms. These athletes had cardiac MRIs, and there was a big workup done. And what they did was look at inflammation of the heart muscle on MRI, and actually 2.3% of these people who had COVID had myocarditis. Here we can see that the benefits of the vaccine outweigh any potential risk of the vaccine. So really, why did the CDC alert the medical community? The CDC wants to study these cases to see if there is a link. They do this with all vaccines. They want to see if the risk of getting the vaccine is greater than getting the disease, if there's a real link, and to be open. This really just proves that we have a robust system of watching and, for lack of a better term, tracking. The CDC and the FDA are being very transparent. They take the issues very seriously, and they want to determine that these vaccines are safe, which they are. Next slide. So COVID in the pediatric population. What do we need to know to make educated decisions? Well, there have been over 4 million pediatric COVID cases in the United States so far. That's currently about 14% of all COVID cases, but that percentage is increasing, probably secondary to more and more adults getting vaccinated, variants, and now that our kids are returning to activities and interacting. 1 to 3% of all pediatric cases get hospitalized. And 3,000 cases of that serious, what we call MIS-C, have been reported, with 900 kids requiring ICU treatments. Unfortunately, we've lost 300 kids to COVID, and COVID is now the 10th leading cause of death in pediatric patients. So what else? We are also seeing long haulers in the pediatric population. these kids are having long-term symptoms of memory loss, fatigue, headache, dizziness, and depression. Two recent studies have shown this rate to be somewhere between 4 and 9% of the pediatric population. Very early data, but it's still being researched. So what's the takeaway? The takeaway is, once your kid is eligible to get the vaccine, get the vaccine. We should all be getting the vaccine. As Dr. Fierstein has said before, the vaccine is free, no matter what your insurance, or even if you have no insurance, you will never, ever be asked to pay for this vaccine. You will also never be asked if you're a citizen or anything like that. All you need to do is prove that you live or work in the state you're getting the vaccine, and you have to prove age. So that can be done by passport, birth certificate. For kids, it can be done by getting a copy of their school records, okay? You do not need to prove that you are a citizen or even documented. So if you know people who are undocumented, we need to get them vaccinated as well. We need to protect everybody. And I leave it as, we all need to get vaccinated. We need to encourage our friends and family to get vaccinated. And I look forward to when we can vaccinate the younger kids. And as Rachel said, it'll just take time. Thank you.
Thank you, everyone. This has been amazing. Rachel, I learned so much from your presentation. I really enjoyed it, and I think I can explain it a little better now. One of the questions, and I don't know if you know the answer to this, but why is it mRNA vaccines that have more severe symptoms than traditional vaccines, or is it just because COVID seems to be a much more severe illness than a lot of the other things, or COVID seems to affect every system in our body more than other vaccines?
This for me?
Yes.
Yeah, so that's a great question. We don't necessarily know why these vaccines, tend to have a lot of the flu-like reactions within a day or two after vaccination. Maybe one of the doctors can talk about if it's different than other types of the other vaccines as part of the pediatric series.
I can try and answer a little bit of it, but like I was saying before in my presentation, I don't think it's that the mRNA vaccine is necessarily causing more adverse reaction, if that's what you're discussing in terms of the reactions to the vaccine. But I think that it's in the spotlight right now. We're kind of seeing it in the media, we're seeing it broadcasted, we're seeing it advertised, we're seeing it promoted. So we don't see every pediatric patient that comes into the office that gets an MMR vaccine. I'm sure there's a lot of patients that I see in my practice that are coming in for evaluation for reactions to those vaccines or the Tdap or things like that. But I think a lot of it has to do with the media, the abundance of vaccinations being given. And as I said before, the immediate reactions and adverse reactions are kind of slowly making their way towards other routine vaccinations.
Thank you. And for those of us who are old enough, the Shingrix vaccine, was that what you're going to say?
Exactly
the Shingrix vaccine has horrific side effects. And people were waiting online for that as well, because shingles disease itself is so serious, can affect your vision and all of these things. That risk benefit, we took it, and COVID is more serious than shingles in many, many ways. Okay, this one I'm going to send to Dr. Levene, because he and I have been dealing with this one. How can we assure, or how are the vaccines stored at the correct temperature once they are brought to the pediatrician's office? Does anybody have to worry that we're not storing them properly?
Well, no, you don't need to worry that we're not storing it properly. The greatest news that we've had recently is the changes in the Pfizer storage requirements. Now it's, we heard about this ultra freezer, minus 90 degree Fahrenheit. And then we were allowed to store it at 2 weeks at a regular freezer. And now you're allowed 2 weeks in a regular freezer and 1 month actually in a refrigerator. in New York State, the state is distributing the vaccine. So we're very careful. There's tracking systems on when we're moving the vaccine. When Allied 2 weeks ago started giving the vaccine for the first time, and we had to document the cold chain distribution, we were very careful. We had dry ice. It was a process that had to be documented and reported back to the state. Tomorrow morning, I'm headed to Dr. Fierstein's office to pick up our next batch, and we'll be doing that. So I would not, that's something we really do not need to worry about, because if there's any break in that chain, those vaccines are not given.
Right. Of all professionals, pediatricians really are the experts in giving vaccine. And even though the colder temperatures of the Pfizer vaccine are unusual, we're well prepared to deal with all of that. Dr. Kreiner, there are a few questions about children with autoimmune disease or type 1 diabetes, and should they be getting the vaccine, or should they worry that it's going to put them at risk? Or if you're at risk of an autoimmune disease, like you have a family member with type 1 diabetes and you have the genetics, is that something that you need to be worried about?
So also a very good question. And I think that the benefits of getting the vaccine outweigh the risks of any complications. There haven't really been significant studies to show that there is harm in giving it to those with autoimmune issues or type 1 diabetes. The only issue that I might see come across is that they may not mount as robust of an immune response to the vaccine, but any protection for those patients specifically is probably very beneficial in compared to any complications they might have from their underlying autoimmune illness. So again, benefits outweigh the risk, but if there's any concern or any issues or symptoms that patient might have, it's always important to talk to their specialist or whoever follows them for that condition.
Thank you. Rachel, I'm going to put this one back to you. It seems that herd immunity is going to be hard to achieve, at least nationwide. What happens if we don't hit it?
Yeah, that's a great question. And it does look like this magic number of herd immunity may be very difficult to get to. And what will likely happen is that COVID-19 will become what's called endemic, kind of like seasonal influenza. It'll be something that we live with, and we just kind of learn how to live with. But because so many people are vaccinated, it's going to reduce the severity of the illness altogether. And because most importantly, a lot of people are vaccinated, hopefully greater than 50%, it will reduce the strain on the healthcare system so that we're not worried about overwhelming the hospitals, and people will have access to the care they need should they get COVID, and we won't see the hospitals so crowded like we did in the early stages of the pandemic.
Thank you. While you're up, how does the number of participants in the study in the 12 to 15-year-olds compare to other vaccine trials?
That's a great question. I don't know the specifics, but I do know that for all of these COVID-19 vaccine trials, is that the enrollment far exceeded any other vaccine trial that's ever been done for any of the other vaccines. So enrolling upwards of 30,000, 40,000 people in the adult trials was kind of unheard of before this.
Thank you. And then could you just take a moment and explain the difference between EUA and FDA? Like, why didn't they just go for FDA approval?
It was all about time and need. So emergency use authorization allows us to bring these very needed vaccines or therapeutics or diagnostic testing, like all of the COVID testing that was done in the early stages of the pandemic, to patients much earlier than it would be with full authorization. There's no difference when it comes to safety or efficacy. You have to prove to the FDA that it's safe and it works. The only difference is cutting red tape. And we need the full authorization or the full FDA approval, because emergency use authorization can only be done when a public health emergency is declared. So I hope that in the not too far future, we will no longer be under a public health emergency, and that we will no longer need emergency use authorizations to be done. So we'll need these vaccines for the future, so we need the full authorization. And both Pfizer and Moderna have submitted for full authorization, and the process just takes a couple months instead of a couple weeks.
Thank you. Dr. Levene, would adolescents have enough immunity with one dose of the vaccine, since some of the side effects seem to be coming after the second? Can we just skip that?
Actually, no. What they and there's just some data that I haven't even finished reading that came out today that shows that one dose does not give you enough protection, and that the 2-dose regimen, assuming we're talking about mRNA vaccines, gives you so much greater protection, especially against the variants.
Okay, thank you. Dr. Bosin, so when you talked about infertility, you talked about a year being the definition. So it kind of seemed a little like semantics.
Right.
So how do we know that it's not going to affect your ability to get pregnant?
Well, I think one of the ways to answer something like that is to say, what will COVID do in terms of fertility or infertility a year from now, or 2 years from now, or 3 years from now, when studies may be done? So the question, yes, is semantic, but it was based on data that we already know. One is that we can't tell if it's caused infertility because it hasn't been around enough to define infertility. And that there have been no studies or even anecdotal reports of people trying to get pregnant who have either gotten COVID or the vaccine in terms of their fertility performance. Some of the things that and Eric Levene touched on it in terms of COVID, and maybe even in the long haulers, where there's a certain amount of stress that everybody's been living under over the past 16 to 18 months. And we all know that stress in and of itself can cause infertility, in addition to other things. So I think that there's, like I said, there's 2 ways to answer it. One is, does COVID itself cause the problem, and when would we know that? And what we know now, meaning that there has been no retrospective studies or double-blind studies that have shown anything having to do with infertility, nor do we clinically think that there's an issue with infertility.
So, I mean, I think this gets just to the basic fear,
Yeah.
right, of something new and unknown. And, COVID itself, we know, does lots of bad things, and can cause clots and can cause things. And you wonder what that can do to children who are going through puberty and all of those things. And I agree with you, we won't know those answers. But is there anything in your knowledge, like, other than people trying to sow fear, why would we think that this is going to affect fertility when no other vaccine has ever affected fertility?
I tried to, and I queried people I work with and tried to do literature search and sourcing, and I really couldn't find where this originated from or who it originated from. It could just be pure fear-based, where there's a fomenting of an issue because somebody thinks it's happening. But like I said, I don't look at it in terms of the vaccine so much. I look at it in terms of the fact that what happens to people who aren't vaccinated and, God forbid, get COVID and maybe become a long hauler or something else, and we find out 3 or 4 years from now that one of the long-term effects of COVID may be infertility. Now, this is just conventional wisdom, which is maybe where that theory in terms of infertility came from in the first place. I have no scientific data, and I'm just saying that that's something that could happen 3 years or 5 years from now when studies are done. But I think to be
For
scientific
COVID itself, not
from COVID itself, exactly. Yeah. So if we don't even know what the effect of COVID is in terms of fertility, performance, or infertility a few years from now or a year from now, certainly I don't know how we could say that like I said, how, like, infertility is defined as a year really of trying to get pregnant. And the vaccine hasn't even been out that long in the general population. So it almost seems to me like you're contradicting terms. But I respect the questions or the fears of any patient that asks those questions. And I think it's our job to educate and redirect. And unfortunately with COVID, some of us, the playbook is written on a weekly basis or even a daily basis, where we could be talking about something now, and 2 weeks from now, there is a study that comes out that's scientifically proven to have a problem. I'm not saying infertility, but I'm saying something else. And I've dealt with very, very ill pregnant patients. And I've dealt with very ill long haulers that are pregnant. And it goes back to the fact that, unfortunately, ACOG doesn't come out and say you should have the vaccination. It does the Society for Maternal Fetal Medicine. Luckily, you could fall back on the CDC guidelines. But the real fear is that the patients who are at real risk for becoming very, very ill, we want to make sure that at least those patients enter into a conversation with their provider. And hopefully the whole thing with fertility or infertility will come up as a question. But all we can do now is redirect those questions to what we know, and even say that, hey, we don't know. And I think that that's being honest too, not just for fertility or infertility, but for other things that affect women's health as well.
Yeah, there's a lot we don't know about the disease itself.
Right.
I don't know if everybody on the panel knows, but in the audience, measles has a viral component that comes back 30 years later that causes encephalitis and all kinds of brain issues. And, truly I worry about COVID and those kind of effects down the road, because it does seem to affect every system. We laugh about you can't smell and you can't taste, but that means it's in your brain, right? That's where those nerves are. And that scares me.
Right. That's affecting the cranial nerves. And if I can interject, I was pretty sick with COVID and wound up with immunotherapy way before the vaccine came out. Luckily, I didn't lose my senses for a long period of time. But you're right, it's a very scary thing. And it's exactly what I thought, that it's in my central nervous system. And we don't know in 2 years or 5 years, how that can affect it. There was another question, if you don't mind me further interjecting, that I saw about how, how the reporting for pregnant patients with vaccines is going. I can try to find that question.
Just answer it.
Yeah, I'm trying to, I was trying to find it so I could say, the thing is that, like I mentioned before, is I'm just going over to my slide now, is that at the time that I wrote this, that there were 94,000 participants in the CDC's VSafe after vaccine health checker that were pregnant. So at the time that this was written, the CDC was tracking it. But now, since vaccination has become more widespread, I think it's going to be very difficult to really get all the data on those patients who were either, periconceptual or very early in their pregnancy, in terms of how to extract data from that going forward.
Thank you.
Mm-hmm.
Dr. Levene, what about my child needing a meningitis vaccine? Do I have to figure out the timing of that, or where are we now with that?
That's good. And as Dr. Bosin said, everything changes every week. So we used to say you can't have any vaccine 2 weeks before COVID vaccine or 2 weeks after the second vaccine. Well, that changed a few weeks ago, and the CDC said you don't have to time it, and you can actually, what we say, co-administer it. You can actually take your COVID vaccine and another vaccine at the same time. So you do not need to time it, especially now with our 12 to 18-year-olds. They're coming in for camp physicals and school physicals and getting their meningitis vaccines and their Tdap vaccines and the meningitis B vaccine to go to college. So Don't worry about it. Just schedule it. Get your vaccine, get your COVID vaccine, and all your other vaccines at your normal time.
Okay, this one actually, I've been asked a lot in the office. My child is turning 12, in the middle of July. Can I sign a waiver and just get them the vaccine before they go to camp?
I would love to say yes, but unfortunately, no, you cannot. You must be 12 to get it. And because we're gonna, if you're getting it in a pediatric office, like any of our allied offices, we know how old you are because we have all your records. But if you're going someplace else, you're going to have to prove it. That being said, if any of the kids are going to sleepaway camp, you've got to remember that if you're getting your first one now, they need to get that second one before they leave to go to sleepaway camp. Or if you're going to be on vacation, you need to be planning for this because it is 3 weeks from first dose to second dose. Is there a little bit of wiggle room? Yeah, there's a little bit of wiggle room, but there's not like, we don't want to do it 3 weeks after the supposed time frame. So planning is important.
Right. Although I think technically you're allowed to give it up to 42 days after the first one. And if you were to, you're supposed to shoot for 21 days. You should plan on 21 days, but you can give it up to 42 days. And if it were after that, they still say to give it. So, just at that point, you're not within the guidelines. So you just never know. Although there was a recent report saying that they think the antibody response is going to actually be greater if there's more time in between the vaccine. It was just one of those things, I see Rachel nodding, like where you want to get people to the highest level as quickly as possible, which is why they picked the shorter time frame. Do you want to comment on that, Rachel?
Yeah, that's exactly right. We know that that it's the timing of the second in relationship to the first was done about what we know about how long some components of the immune system stick around in our bloodstream and when it's going to be optimal to boost or raise that response. The study that Dr. Fierstein was talking about, where antibody levels may be higher in people that receive the booster or the second, maybe 6 or 8 weeks after the first. I think they're coming out of countries in Europe. The thing is, we just don't know. They weren't done on as large of a scale as they were with the clinical trial participants that were done with 30, 40,000 people. So anytime we deviate from the data, we just don't know.
Thank you. This kind of goes towards conspiracy theories. So I'm going to throw this to you, Dr. Kreiner. I have many friends say that these are not vaccines. Can you clarify what a vaccine is, and is this actually a vaccine?
Interesting question. That's a very good question. A lot of people are questioning the speed at which this was produced. So a vaccine, can be a multitude of things. There are many different vectors or ways that the vaccination gets into the body. So like I said before, there is a mixture of different components, vaccine components like formaldehyde, thimerosal, and there's also excipients, which help in the absorption or the recognition process. So a vaccine, in essence, is the way to inoculate the body or the immune system so that they can fight infection. So the measles, mumps, and rubella vaccine it's actually a live virus, but it has a way for the body safely and hopefully efficacious with efficiency for the body to recognize and elicit an immune response. So should they be exposed to that virus down the road, the body has these memory T cells or memory B cells to come out of the bone marrow and elicit a response. So a vaccine is something that helps to elicit an immune response, which the mRNA vaccine from Moderna and Pfizer does, as well as the J&J vaccine.
So to kind of condense that all, is this a
Yes.
vaccine?
Yes. Yes, it is a
Right?
vaccine.
Is there anything about a vaccine that the COVID vaccine doesn't fulfill?
No, 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 no.
Right.
It is exactly what a vaccine should do, is, and hopefully will be down the road.
Great. One other question. I guess, Rachel, I don't know if you'll know the answer to this one. You get nervous when I call on you.
I'll take a shot at it. If I don't know, maybe someone else will.
With a small, I have a 12-year-old. This person has a 12-year-old, but they're on the small side, or they're just 12. Is it possible that this dose is going to be too much, and then we're going to find out that the 11-year-olds really needed less, and this child should have gotten less? Like, is that a risk?
Not necessarily. I can give a personal anecdote. I'm on the very, very, very small size. For an adult, I'm probably the size of maybe a young teenager, and I got the full adult dose. So
yeah, I mean,
I'm fine.
Yeah, I'll say that there really is no vaccine where we adjust the dose by weight. In pediatrics, we adjust medications by weight, but we do not adjust vaccine dose by weight. And actually, the only vaccine that we used to give less of a dose to was flu, and we don't even do that anymore. We give the same dose of vaccine from 2 months of age until 18 years of age. Am I wrong, Eric or Robyn? Is there any vaccine where the dose changes based on the age or the weight? Oh, I lost you here.
No, I mean, in fact,
No,
for instance,
but I-
pneumovax, we give to 65 and up, and we also give it to, sickle cell patients who are 1. So it's an adult vaccination, but has been shown to be effective in the younger population. And yes, they might elicit a more robust response, but who wouldn't want a robust response and more elevation in antibodies to protect them? So if anything, in my mind, an adequate dose versus a little bit less of a dose would be beneficial for them.
Although I actually did think of with the Tdap, right? There's more vaccine and more for the younger kids than the older kids, right?
In tetanus, it's the same, but in the diphtheria and the pertussis part of the Tdap versus the DTaP, the DTaP we give to the younger kids, there's more diphtheria and more pertussis in the first part. So yeah.
Yeah. So I would not worry about that. I would just go by whatever the guidelines are and take the vaccine as soon as you can. I think we've gotten, go ahead.
I can kind of add to that. Within the clinical trials, there's a range of children of adolescents, 12, 13, 14, 15. There's a range of children of all sizes amongst the people that were enrolled, and that they purposefully do when they enroll participants to make sure that they accurately represent the population.
Okay. Robyn, since you take care of adults, I'm just going to ask this question. If you have the choice of Moderna, Pfizer, or J&J, do you have a preference?
No, we've been telling all our patients, whatever you are able to get. If there is an issue with an allergic reaction or a concern for a reaction, we're always happy to see you and guide you in terms of what vaccine may be more beneficial. But again, the benefits outweigh the risks, and I can't, emphasize that enough for all these patients. And again, if you have any questions, we're out there to help guide you and educate you and provide you the best information possible. And if you're hesitant to get it, we're there to listen, to your concerns and help guide you to make the best decision possible.
Yeah, I want to echo that. All of the allied physicians are ready to answer your questions. All of our offices don't necessarily have the vaccine. Somebody asked that in. Because of the fact that you have to open it in vials of 6 and give out a certain amount in a day, not all of our offices are able to handle that. So, but you can get the vaccine in any office that's giving it. So if, you know, an office nearby is giving it, you don't have to be a patient within that office. Any patient within Allied is welcome to get the vaccine there. Anybody need to say anything in closing? I think we covered a lot. We've gone through the myths, the risks, the benefits. Overall, we are all coming down on the side of vaccinating as soon as you have that ability to. I want to thank everybody for joining us tonight, everybody on the panel, everybody in the audience. I hope we answered your questions and did so in a manner that you found helpful.